Thank you very much for asking me to lead a discussion on post-remission therapy for AML patients who aren't going on to a stem cell transplant. And I have kind of the perfect people in the world for this discussion. So I'm hoping that all of you will join me in trying to address a couple of specific points. So one thing that I've been thinking about recently, and I'm curious what my colleagues feel, is that is it possible that it just doesn't matter so much how to get patients into remission anymore with AML? Is it possible that there are now enough ways to slice and dice getting people into remission that our focus really is now on the post-remission space? And I just think back to, 10 years ago or 15 years ago, there were these really, really, really dramatic decisions that had to be made when a patient was coming in with newly diagnosed AML of what are you going to do for induction? And in my mind, the real reason for the huge decision is that if you were relegating somebody to not getting an intensive induction, you were basically kind of making a decision out of the gate without necessarily explicitly saying so. But if you were giving somebody single agent low-dose cytarabine or a hypomethylating agent, you were basically saying, all right, well, we're going to do our best here, but this isn't somebody who is really likely to have long-term survival. So we were really, really trying to get patients to intensive induction because that was the only path going forward that was going to lead anybody to survival that was likely to be measured in more than 9 months. And now there are all of these papers coming out that, well, there are a lot of ways to get people into remission. And there are an awful lot of studies that suggest, for example, that there are at least a large subgroup of patients between 60 and 75 that probably if you use HMA venetoclax or CPX, they both will get the patient reasonably into induction. You might not even have to have a 3-hour conversation about it out of the gate because if it works, it works. If it doesn't, you can try the other one 2 weeks later. So there's almost, I think, of a bit more of relaxation about being confident that with the exception of some of the truly complex karyotype TP53s, but even with those, we're probably going to get the patient into remission. But then what are you going to do, which is going to be the focus of this talk about what do you do once they're in remission. But I'm just curious for some immediate reaction from colleagues about, is it possible that we can just get patients into remission without as much drama or discussion that what we used to have? Or is that a false concept?
So Gail, let me just push back a bit. I suppose two thoughts immediately. The first is that with our current induction strategies, either in fit or unfit, there's still a significant number of people who actually don't achieve a morphological CR. If you look at the Palier clinical cancer research study, that Veneza versus, I mean, the outcomes in that high-risk population aren't great, actually. My reading of that paper was that the CR rates were about 60%. And similarly, I think of Jeff's paper with CPX. I mean, there's still a sizable proportion of people, particularly with adverse risk karyotype, who aren't going into CR. So that would be one pushback. The second,
but it's not. But wait a minute, that's not really a pushback to what I'm saying, though. So a lot of people won't go into remission. I will stipulate that. Okay. But if they're not going into remission, they're not going into remission. So I guess my initial point was, and I'm just wondering if you're actually pushing back. I'm agreeing with you that there are certain patients who can't get into remission. And I think I said the same group as you did, and I worry about those for sure. But for a lot of other patients, if you give them, if they have an IDH1 mutation and you're giving them Ivo and azacitidine or Ven and Aza or CPX, there are a lot of patients who are somehow going to get into remission with more of a variety of choice than what we used to have.
Well, that's true. I was pushing back, I think, at perhaps maybe I misinterpreted it. It was slightly Panglossian spin, which was that most people are going to get into remission, which I would suggest that there's still a real unmet need is actually how we optimize CR rates, whether it's with intensive or non-intensive. And I would also, just mindful of your wonderful talk in Munich at that meeting in February, which people still talk about, Gail, is we are aware of a lot of phase 1/2 data with triplets, non-intensive triplets, but they're phase 1/2 data and they haven't gone through randomized trials. And you have to be aware that often when this data goes through randomized trials, it doesn't turn out to be nearly as good as it is. So I'm just suggesting that we mustn't ignore this very large bucket of people, whether it's fit or unfit, where we are failing them, all right? And then the second question I'd have for you is, what do you mean by remission? Are you meaning that we would stick with conventional definition of morphological, or do you think that actually we should be saying remission actually in 2023 should be a much more stringent criteria? I'd be interested in your thoughts.
So yeah, so I mean, thank you for the easy segue. So where I was trying to lead, and maybe Gert can even jump in here, is that, okay, so if you are using an induction strategy to get into remission, is it now, with consideration of getting into deep MRD negative remission, how deep does it have to be and how quickly do you have to get there? Because I think Jeff alluded in our prior conversation that, so let's say you have deep measurements of MRD. What does that even mean? Is it going to be by sequencing? Is it going to be by flow cytometry? How deep or PCR, how deep can you go? And what is the definition of that with respect to what you do next for the patient? So I guess the way to frame this is, if lower intensity therapies are able to get you to MRD negativity, at least by flow, after repeated administrations, which I think lots of groups are starting to show, and Ravandi led the data out of MD Anderson showing that if you kind of wait long enough, you'll get to MRD negativity. And even in Viali-A, they looked at this, that it'll take a while to get to MRD negativity. But what are we supposed to do with a patient in remission? Are you trying to get them, if you bomb the patient up front with something heavy duty and they get into a more deep remission out of the gate, what's the prize then for that patient? What is going to happen to them in the quote unquote post-remission zone? So Gert has been talking about MRD now longer than anybody. So how do we use the selection of the induction in order to yield an MRD negative result that buys the patient some prize then in the post-remission setting? How do we put that all together in 2023 and a half?
An honest answer is we don't know, and the shortest way to answer. But most of the data is available, I think, in a favorable group of patients. There we know that patients who are in a complete morphological remission and still have low level of MRD for the NPM1 by PCR measured, will never show relapse. So there it doesn't count that you need the deepest possible remission, but even a lower level of MRD can cure those patients. I think for the intermediate group, the jury is still on. We really don't know. And coming back to your question, is every complete remission the same, either achieved by low intensity or intensive treatment? Also there the answer is we really do not know it yet. For example, we do not know whether the quality of remission after low intensity treatment is in the end the same as a remission after intensive treatment. That's also the reason why most of us don't dare for younger patients to use a lower intensity treatment to achieve complete remission, although we now know that we can achieve complete remission. But the reason that we don't dare is that we don't know yet.
So here's a question. We have representation. So we have the east side of the United States, the west side of the United States, we have the southern part of the United States, and then we have Japan. We've got a whole world here. Let's just talk about NPM1 for a minute, since several of you have brought this up. So simple question. You have a patient who could, I'm not giving you an age, but a transplantable patient. In the different parts of the world, you have an NPM1 mutated patient. I'm not telling you the rest of the mutational profile, who is in remission, who has a morphologic remission, as well as an NPM1 negative by PCR remission. I'll start perhaps in Japan. Are we transplanting those? Are you transplanting those patients?
You mean in the first remission?
In first remission. Let's say the patient is perfectly well for a transplant and has a donor. They're in remission. They have an NPM1 mutation with or without other co-mutations. Yes, no.
Probably I will not transplant this patient during his or her first remission.
Okay. And now I'm going to move.
Probably I will prepare, for example, checking HLA of the patients or checking the availability of donor, but I will not perform transplant.
Okay. And in Seattle, are they getting transplanted at the transplant center of the universe or no?
I think we would actually pay attention to what you try to suppress, the context of the mutation, age, and what else comes with it. So I don't think I can answer your question how you asked it.
So some of the NPM1s would still be transplanted.
Yeah, I mean, I think there's, the high FLT3 ones we don't like. I think I'm personally impressed by the data that NPM1 isn't all that great if you're older. So where the prognostic significance seems to drop down. So I think that would factor in to some degree.
Okay. And what about Charlie?
And then obviously the adverse karyotype NPM1s, that's a different beast altogether too.
Okay. Charlie, same answer,
Yes.
different answer?
Well, I think similar to actually Roland, obviously, we've been very heavily influenced by the Grimwade data. And it's also there's the Balsat data from the French group. And I think unquestionably, Gail, those patients with an isolated NPM1 mutation have a good MRD response, perhaps particularly younger people who don't need to go to transplant. That we're comfortable with. And actually, I have to be honest with you, many of my colleagues would be actually rather more theocratic about this, and they'd say anybody with an NPM1 mutation, regardless of whether there's a high allele burden FLT3, as long as there's a good MRD response, are fine. And in fact, Nigel Russell has a presentation on that at this coming ASH. But a lot of us are skeptical about that, these analyses, because I think Roland's absolutely right. It's the mutational context. I think it's age. As well. And my worry is that we're overplaying this. So the answer to your question is in younger people, isolated NPM1, unquestionably, they don't go to transplant. But there's still a group of older patients, particularly if they have a FLT3, where I don't think we have enough evidence, or I haven't seen it, to say they shouldn't go to transplant. And that's an established curative therapy, and that's what they get.
And in Sweden, where there is good snow?
For NPM1 mutated without adverse features, we do monitoring, frequent monitoring, and we don't transplant in first CR. But with the rising MRD, we do a transplant in molecular relapse, so to say. With those with other adverse features, we mostly want to transplant, but it's hard to say which features that calls for transplant and which does not.
And for the frequent monitoring, may I ask, are you using peripheral blood PCR monitoring?
We
or
do.
What is the monitoring?
Monthly blood tests and quarterly bone marrow.
Monthly blood tests.
So, but,
have you adopted at all, out of curiosity, for the patients who may be showing a rise, have you used venetoclax or any other type of, is it a common practice to try to intervene when it is rising, or what do you typically do? If you're noticing something that is rising, do you recheck it and see if it falls, or how do you approach that?
Well, it depends on the kinetics of the rising and the availability of a donor. So if we have if we have slow rising and a donor available, we don't give further treatment, but otherwise we can give Veneza in waiting for the transplant.
And waiting for the transplant. Yeah, I struggle with that because we have been using a lot of interception type of strategies with that, and it's very effective. And then you're MRD negative, and then the question is, well, now do you go or do you not go to transplant? I think it's a challenge for some of the patients who are not excited about going to transplant, or who are perhaps borderline if they're able to get MRD negative with anything, with either oral azacitidine or with venetoclax or whatever you're trying. I'm curious then, Hovan, what does obviously Hovan has tons of data on this. What is the current standard practice?
I think we have the same policy as Sweden, because we belong to the same trial group. So we rely on the NPM1 independent of the risk features, because we do not really know what are high risk features in NPM1 mutated, and we rely on the NPM1 MRD results frequently monitored, and in case of a rising level, we intervene with Ven-Aza until transplant. Yeah.
Until transplant. And I think in Germany, even though it's not technically it's a parallel group, I think it's the same, right? I think that they don't look at the other features, they go with the NPM1. Am I right?
Yeah,
I think
correct.
that's true. And in Spain?
Well, in Spain, we do not transplant patients with NPM1 mutation and without FLT3 ITD, or with a low allelic ratio. We still use the allelic ratio, but we do transplant patients with NPM1 mutation with FLT3 ITD, regardless that they get a MRD negativity after induction and consolidation. And we also give preemptive therapy for patients, or we treat molecular relapses with Ven-Aza, and the results we have in a limited number of patients the results are very good, with many molecular remissions, and depending on the center, the patients continue on venetoclax or are transplanted. In my institution, they are transplanted after achieving a molecular remission.
And just to round out this discussion, because obviously post-remission space is complicated, but NPM1 does cover a lot of patients. So Jeff, to round out the US view, US tends to transplant a lot. Europe is more relying on NPM1 data. It's Florida. Where's Florida?
No, I mean, I don't have much to add to what I think others, Charlie and Roland especially, said. I think that it's a diverse group, the NPM1, and we at least recognize now we're hoping to publish soon some data showing that the presence of MDS-like or secondary mutations adversely affects NPM1. So we do not approach those patients the same as we would an isolated NPM1 or one without adverse mutations, in the same way we would favor transplanting those patients regardless of MRD status, if they have baseline adverse molecular features. So it's a mixed bag, and it's also, a consideration about how can you manage these patients without the transplant, which I think was sort of one of the topics you were kind of alluding to in the beginning, because not all NPM1 patients are transplant candidates. Even if they are, sometimes they don't choose to go down that route. If there's potentially effective maintenance therapy, which you have clearly demonstrated that there is, even if it may not be curative. So I think there's a lot of variables that have to be considered, not the least of which is the patient's preference. And
I
the
really
availability
I
of
really
other-
appreciate everybody stepping into the discussion. And one of the things that I think that I've proven is that even a discussion that seems so innocent in a title for 15 or 20 minutes to post-remission therapy, it's gotten quite complicated in AML to even have this discussion, because if you even just talk about one molecular subgroup, which is a lot of patients, you can hear that there are different ways to kind of slice and dice this currently. It certainly seemed clear that everybody was pretty focused on having MRD testing in the remission. So I think that's very important, that a discussion of post-remission therapy requires a definition of the remission that you're in. And then if you're not doing a transplant, there is discussion of post-remission monitoring, which is, I think, you know, it's kind of a discussion in and of itself in terms of what different doctors are doing, what they're set up for. And then finally, what is the intervention if you actually see something changes? So just such a simple sounding topic, or what are you going to do for the patient, I think is not so simple. And I appreciate everyone's discussion. We could, I think, spend an hour literally discussing what to do if you have simultaneous measurements and solid measurements on FLT3, for example, MRD testing in combination with MRD testing, and what to do with that. So I think it's gotten quite complicated.